All right, well, hello and welcome everyone. Thanks for joining us this afternoon to learn more about the updated ACO Certification Program application requirements for this year. Many of you know me. I'm Mike Stanek. I'm a Senior Manager on the Health Policy Commission's Healthcare Transformation and Innovation, or HPC team. I manage the ACO Certification Program. I'm joined today by Catherine Harrison, the Deputy Director of the HPC's HPC team, and by Courtney Wright, who is a Senior Program Associate on the team. You'll all get to know Courtney very well through this year's application process. I want to start today with a few housekeeping items. We are going to keep all the lines muted today. Please submit any questions about the webinar content or the PUG as they occur to you by entering them in the chat box. We're going to try to leave some time at the end to get to as many questions as we can, but we will note those that we cannot get to today, and we'll follow up as appropriate. We are recording this webinar. Both the recording and the slides will be available on the ACO Certification Program website after the event. And I'll take this opportunity to plug our office hours series, which will start at the beginning of next month. As we have in prior years, we will open up a phone line, or probably a Zoom, once a week where folks can drop in and ask questions about the ACO Certification Program, application requirements, or the process. And Courtney and I are always available offline to talk one-on-one about aspects of your application, so don't hesitate to drop us an email. So there'll be plenty of opportunities to get all of your questions answered, but more on all this at the end. So this is a brief agenda for the webinar today. We will start off with some general information on what's changing this year and what is not. Then we will walk through the contents of the application. We'll talk briefly about the process and timeline this year, and then we'll answer some questions as time allows. All right, now let's dive in. Since 2017, the HPC's ACO Certification Program has served to provide all payer standards for ACO care delivery and transparent information for the public on ACO structures and operations. As of this year, the HPC has certified 16 ACOs that collectively have nearly 3 million Massachusetts residents attributed to them. We're excited to build on that success and continue to support transparency and learning across the health system in Massachusetts. We indicated last year that as we look toward our third certification cycle for ACOs later this year, we are making some updates to the certification standards. When the program standards were first designed several years ago, ACOs were still relatively new. We focused on recognizing definitional attributes or capabilities of ACOs and creating a baseline understanding of ACOs for both the HPC and the public. In 2017 and 2019, we centered those payer-agnostic standards on core ACO capabilities, including supporting patient-centered care and governance, quality improvement activities, and investments in population health. The ACO certification program standards largely remained unchanged through the first two certification cycles. Now, as the program is becoming more mature, and we've had the opportunity to learn lessons through two certification cycles, we've made some refinements to the standards that we believe will even better facilitate care delivery transformation in the Commonwealth. These changes are designed to build on the existing standards while being intentional about where we steer the program going forward. We are calling this first significant update to the certification standards ACO LEAP 2022 to 2023, reflecting its emphasis on learning, equity, and patient-centeredness. In all of this, we were guided by the recognition that we are all still learning. The national evidence of the relationship between particular ACO capabilities and outcomes is still developing, but ACOs do seem to perform better on cost and quality metrics with time and experience. We believe that fostering effective learning and feedback mechanisms can be an important component of care delivery transformation. Given the range of experimentation and learning that ACOs are engaged in, we're seeking to provide flexibility to ACOs in recognition of the fact that there may be different ways to demonstrate how the ACO meets the spirit and the letter of our standards. The ACO LEAP standards are intended to allow for a variety of ACO approaches and innovations within the framework that we set forth. With ACO LEAP, we purposely embrace the ACO model as a catalyst for learning and improvement among healthcare organizations. In this approach, we were influenced by the National Academy of Medicine vision of a learning health system, which they've described as one in which science, informatics, incentives, culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the care process, patients and families active participants in all elements, and new knowledge captured as an integral byproduct of the care experience. The key elements of the learning healthcare system concept dovetail with what the HPC's investments and policy recommendations seek to achieve, and strongly influence the development of the ACO LEAP framework. Finally, as ACOs continue to transform care delivery, we are excited about the role ACOs can play in advancing health equity in the Commonwealth. As we will discuss, our revised standards layer an additional requirement that ACOs be engaged in intentional activities to promote health equity. Before we get to the ACO LEAP standards, one overarching note about who the HPC certified ACO, the applicant for certification, should be. One concept we have consistently tried to be very clear about in the application requirements and platform user guide document, PUG, concerns who can apply, or in the case of a large health system or provider organization that owns and operates one or more ACOs, which part of the health system or provider organization, which entity should apply. Given the various organizational and legal structures that define different provider systems, we needed to precisely define which entity or which level of the organization we are aiming to certify. For instance, in the case of a health system that, say, already has a Medicare ACO and also added a Mass Health ACO to contract separately and only with Mass Health, which part of the organization should apply for certification? Which part of the organization, which entity or board, is accountable to meet the HPC certification criteria? We've grounded our thinking about this issue in the guiding principle that we've kept all along, that HPC ACO certification is an all-payer or payer-blind program. And we focused on setting care delivery standards that are broadly applicable across different populations and contracting arrangements. And that has led us to defining the appropriate applicant for certification by the language in the box at the top of this slide. In simpler terms, the applicant should be the parent organization or the owner of any of the affiliated individual component ACOs that may hold contracts with specific payers. And all potential component ACOs should be included in the application. So as an example, let's say that ABC ACO is a contracting entity within a health system, and it holds a risk contract with a commercial payer. It owns an entity that contracts with Medicare as an ACO, and it also owns an entity that holds an ACO contract with Mass Health. All three of those entities should be included in the application with the Health Policy Commission. ABC ACO, as the entity with common control of the other contracting entities, would be the applicant. Both ABC Medicare ACO and ABC Mass Health ACO should be included as component ACOs. This is true even if ABC ACO's ownership or control over those entities is only partial. For instance, if it only owns and controls 33% of ABC Medicare ACO. Now, all this has been consistent since the certification program launched. This is just meant to be a refresher. We're not changing anything about how the applicant and the component ACOs are defined this year. This slide provides a snapshot of this year's ACO certification application. This is very much in line with the framework that we put out last year for public comment. To those of you who are able to provide feedback, thanks very much for your comments. I think that as you read through this year's PUG, you will see that the considerations you raised are something that we paid very close attention to in finalizing the standards and the documentation requirements. As we've said before, one of our principal goals is to promote continued transformation in care delivery while ensuring that certification is within reach of provider organizations of varying sizes, experience, organizational models, infrastructure and technical capabilities, populations served, and locations. Our goal with these standards has been to encourage value-based care delivery and to promote investments by all payers in high quality and cost-effective care across the continuum. Overall, you will find that while the while the standards are updated this year, there's considerable continuity with the focus and themes in the background information, assessment criteria, and supplemental information collected in the 2019 application. ACOs applying for certification must attest to certain prerequisites listed here. As in the past, they must also provide some information on risk contracts and quality performance under them. And this year, we have streamlined our information collection around governance and have made the existence of a unique governing body with authority to execute the functions of the ACO a prerequisite. Then, as has been the case for the entirety of the program, HPC certified ACOs must demonstrate an additional layer of functionalities or competencies. The evaluative portion of the application continues to focus on 5 assessment criteria. The revised criteria this year, conceptualizing ACOs as engines of a learning health system, emphasize collecting and using information and data to implement and iterate on strategies for delivering high-value, evidence-based, and patient-centered care. And new this year is a requirement that one of the assessment criteria responses demonstrate an intentional effort to address a health inequity identified by the ACO. We will discuss these criteria in greater detail in a moment. Finally, ACOs are required to provide supplemental information on 3 topics, which you can see here. An ACO is required to provide an answer to each of the 3 supplemental information areas, but you'll recall that unlike the assessment criteria, here the HPC has not set a specific standard for the ACO. These 6 prerequisites represent some basic legal and regulatory expectations for organizations applying for certification as an ACO. Those of you who are familiar with prior certification applications will recognize all of these. 5 have been prerequisites or background items in the past, and 1, the governance requirement, was formerly part of the assessment criteria. You can see here that the ACO must attest that it has, if applicable, obtained a certificate as a risk-bearing provider organization, RBPO, or a waiver from the Division of Insurance, that it has applied or has filed all required material change notices with the Health Policy Commission, that it's in compliance with the any state and federal antitrust provisions, that it's in compliance with our Office of Patient Protection Bulletin regarding an RBPO ACO appeals process, that it has at least 1 risk contract with a public or private payer in the Commonwealth, and finally, that it has an identifiable and unique governing body with authority to execute the functions of the ACO. Like last time around, there'll be checkboxes for these items on the intent to apply form. We'll ask for some additional information on the last 2 attestations, which can be provided in the ACO application form itself. You may recall that governance requirements were an assessment criterion last time. We felt that we could streamline that requirement this year, and that governance more properly belongs in our prerequisites so that we can keep the assessment criteria focused on care delivery. We continue to give ACOs some flexibility to organize themselves as befits their participants, while maintaining the policy intent that they have a dedicated decision-making body specifically for ACO business. We're asking for an organizational chart of the governance structure or structures, and we will have a text box in the application where we ask that you type out the name of the governing body, and if it's not apparent from the org chart, describe some of the key responsibilities of any executive committees that exist in the governance structure. Note that this prerequisite does not require that each ACO be a separate legal entity. An ACO may choose to structure itself that way. That is not our requirement. Our intention is simply that the ACO has a unique governing body charged with executing the functions of the ACO. If the applicant for certification does not hold any risk contracts itself, then only the component ACO governance structures are subject to this prerequisite. Moving down to the next prerequisite, we are once again collecting information about risk contracts in an Excel template this year. We will take a look at that template in a moment. And we are again asking ACOs to report on performance on quality measures included in their risk contracts. There is no template for this quality reporting. ACOs may submit this information in whatever form they have it. For instance, settlement letters or reports from the payers. And we are asking for only performance from the most recent year for which data are available. So here we wanted to provide you with a snapshot of what the Excel template for reporting on your risk contracts looks like. We've had to break it up a bit here to fit on a single slide. Those of you who've done this before will recognize that this is virtually the same as the template that we used in 2019. The only changes are that we have added a column where you can identify the component ACO to which the risk contract corresponds, and we have removed a column that had asked applicants to characterize each risk contract as taking full or partial risk. The template will be available for download through the application submission web portal, but is also available for download right now on the HPC'S ACO Certification website at mass.gov. Some of the fields in the template provide drop-down menus to help you in filling this out. For example, the self-insured, fully insured, both column is a structured field. But in all of the columns, we provided some examples of possible answers in order to clarify what we are asking. When you go to fill out the template, you can clear the red sample text that's there just to avoid confusion. So before we dive into the assessment criteria, I wanted to talk about the kinds of documents that ACOs can provide this year to demonstrate adherence to the standards. For some of the assessment criteria, we will give applicants the option to upload what we're calling primary source documents as supporting documentation for the response. These are any documents that already exist within your organization and could take any number of forms: memos, communications to the network, slide decks, reports, tools, guidelines, etc. And these are just examples. We could imagine a wide variety of primary source documents that an organization might have. The idea here is to hopefully streamline the application process and, where possible, avoid requiring ACOs to generate new documentation for their ACO certification application. If you have ready-made documents that demonstrate adherence to the standards, we encourage you to submit those. Our hope is that this makes the process easier, as well as provides an opportunity for you to showcase some rich content. The alternative, where a primary source document is requested, is to submit an original narrative developed specifically for the ACO certification application and submit that in lieu of a primary source document. If you don't have a suitable primary source document handy or would prefer not to share it, you can provide a description of how the applicant and/or each component ACO satisfies the criterion in question. The PUG provides specific pieces of information we would require an original narrative to have. And an original narrative could just be a Word document or a PDF. It would be uploaded and attached to the application in the same manner as a primary source document. Finally, there are a few areas in the application where we ask ACOs to complete a template provided by the HPC. This is true for the risk contracts prerequisite, as we've seen, but also for the assessment criteria pertaining to population health management and behavioral health integration. In the past, the ACO application has often asked for applicants to develop narratives. But since for these two particular criteria, we are interested in very specific and succinct data elements, we felt it would be easier on applicants to collect this information in a template provided by us. We'll review the confidentiality policies for the ACO certification program later in the webinar, but I will pause here to remind folks that in general, information submitted as part of the ACO certification process is held confidential. For example, it is exempted from any state public records laws, unless ACOs provide permission for information to be released. And we do offer an opportunity for ACOs to provide that permission in the application if they so choose. Now we will do a slightly deeper dive on each of the 5 assessment criteria, since these are the standards to which ACOs will be held. We'll start each of these off by showing you the language of the standard, and then we'll talk a bit about how exactly applicants are asked to show that they meet the standard. This first criterion here builds on the program's long-standing commitment to patient-centered care. It builds on the patient-centeredness components of our prior standards while widening the scope of ACO activities that demonstrate patient-centeredness. One of the things that we learned in working with all of you over the past 2 years is that you're trying out different strategies for understanding your patients, and we tried to provide a lot of latitude here in recognition of that variation. So here we would be looking for a demonstration of activities the ACO uses to monitor and assess patient experiences or perspectives. This could include intentional use of patient experience surveys or systematic use of patient and family advisory councils to gather insights. We will further ask for a demonstration of how the information collected is used to inform strategy in the ACO. That could be shown through things like written plans or a description of a recent initiative to improve an aspect of the patient experience. The AC 1.1 criterion is a great example of one of several places where the application allows for a range of possible approaches. ACOs choose from a menu of potential documentation options and provide one piece of documentation to demonstrate how the ACO monitors patient experience or preference. If your organization is using multiple strategies, you only need to show us one of them. I would recommend picking the more prevalent or primary approach that the organization uses. Our intent here is that documentation included in the application be broadly representative of the ACO's approaches and strategies. As for what that documentation looks like, some suggestions for what an appropriate primary source document might be include things like patient survey instruments that you use or results from such surveys. It could be some summary of information derived from focus groups or online communities, or it could be some demonstration, like meeting minutes, of special attention paid by the governing body to consumers and a patient and family advisory council, or to the lived experience of consumer representatives serving on the governing body. The PUG lays out some potential or suggested documentation options like these, but we're happy to work with you as you prepare your application if you're unsure whether a potential document suffices. For AC 1.2, we're looking for one piece of documentation to demonstrate how the ACO uses that information obtained in AC 1.1 to improve the patient experience. A primary source document showing that could be something like a presentation, written summary, memo, or internal communication describing a relevant initiative from the past 2 years to improve the patient experience. And again, if instead of a primary source document, for either of these criteria, if you choose to develop and submit an original narrative, the PUG specifies some information that narrative should contain. We wanted to put this in context and provide some sense of what this will all look like in the application itself once you're able to log into the application portal. This is a mock-up, but the real thing should look pretty close to this. And I apologize for the small text. It might be a little bit difficult to see. But you'll see that much, but not all of the language from the PUG will be replicated in the application. So you'll still want to keep your copy of the PUG handy while you're working on the application. Since we're allowing for a variety of different ACO approaches towards satisfying the AC 1.1 standard, you can see that you'll have to select in a checkbox the approach that your ACO is pursuing. Our requirement since the inception of the program has been that the applicant and/or all of its component ACOs must meet each of the assessment criteria to receive HPC ACO certification. The exception being in cases where the applicant for certification does not hold any risk contracts, in which case only the component ACOs need to meet the criteria. If an applicant has multiple component ACOs that use different approaches or initiatives, it must submit separate documentation, that is at least one document, for each component ACO. If that's the case for your application, you may have to check multiple boxes here to reflect the breadth of your responses. Once you've checked the box or boxes, you must upload either a primary source document or an original narrative as documentation. Again, if you have multiple component ACOs that are using different approaches, you'll need to upload one document for each different approach. For any primary source documents uploaded, you must provide a short description of a document in the text box. If you have a couple different documents corresponding to different component ACOs, you'll need to provide a short description of each. These descriptions provide us with context on what the document represents, which component ACO or ACOs it applies to, and any other context requested by the text box. This is to ensure that we at the HPC don't need to keep following up for clarifications as to what a given attachment is or represents. The PUG offers some ideas about what sorts of primary source documents you may be able to draw from, but the examples provided are not exhaustive. You are welcome to consult with the HPC as you're compiling your application if you're unsure about whether to use a particular primary source document. If in any instance you do not have a suitable primary source document, you can submit an original narrative describing how the ACO meets the standard. The PUG contains more detail about the required elements of the original narrative for each criterion where one may be submitted. We'll offer a more in-depth demonstration or refresher on navigating the application portal at the end of the summer. But as shown in this mock-up, you will have the opportunity to upload your documents next to each question component. The second assessment criterion recognizes the importance of culture to ACO performance. Here we focus on the ACO fostering a culture of continuous improvement, innovation, and learning to improve the patient experience and the value of care delivery. This one is a bit of a hodgepodge. We contemplate a variety of different ways an ACO may be fostering such a culture, from citizenship activities to internal financial incentives, and we would ask the applicant and/or component ACOs to demonstrate two approaches. So as I said, we are looking for documentation of two approaches. The documentation here could take any number of forms. It could be things like minutes or other documentation of ACO meetings, organizational management activities, or recruitment strategies aimed at advancing a culture of improvement. It could be things like dashboards or other tools for tracking system or ACO level quality and financial metrics against ACO goals by leadership, or a narrative describing how the governing body or bodies set strategic performance improvement goals. It could be a memo, overview presentation, or internal summary demonstrating implementation of systems learning, like Lean, for instance, and/or process improvement approaches, or an example of an initiative where frontline staff identified waste, inefficiency, or quality improvement opportunities and were empowered by leadership to test and/or scale proposed solutions. It could be things like score sheets or written criteria for evaluating potential clinical or non-clinical affiliates or partners, for example, on factors like use of team-based care, communication and/or data exchange, coordination with community-based services, care transition protocols, cost, quality, or access, etc. Or it could be plans or summary documents describing an ACO or system-wide strategy for primary care transformation based on advanced primary care principles, including continuous quality improvement. And again, if a primary source document isn't available or appropriate, you can put together an original narrative describing how the criterion is met. Having contemplated the leadership role in driving an ACO-wide culture of performance improvement, here we turn to ways the ACO supports frontline clinicians to decrease provider practice variation and increase adherence to evidence-based guidelines. This criterion focuses on the ACO commitment to using the best available data and evidence to guide and support improved clinical decision-making. ACOs will be asked to demonstrate that they have adopted processes or tools that make available reliable, current clinical knowledge at the point of care. They could show this through a description of an initiative to reduce low-value care, or an example of an evidence-based protocol or structured learning opportunity made available to ACO providers. ACOs will also be asked to demonstrate that they offer actionable data to providers through things like performance feedback reports or data analytics. Here again, you'll see different pathways or options available to applicants for fulfilling this requirement. That will be represented by a checkbox in the application where you will indicate which approach or approaches the applicant and/or component ACOs use. The sorts of ready-made primary source documents you might submit for AC3 include things like some kind of material or presentations describing an initiative to reduce low-value care, or internal communications or documents encouraging the use of a particular decision support tool or evidence-based protocol among clinicians. It could be things like an event agenda or summary of a structured learning opportunity, or an internal summary or dashboard tracking use of a particular clinical decision support tool. And for AC 3.2, it could be things like a template for feedback reports that are provided to clinicians, or a de-identified performance report, or some demonstration of data analytic capabilities provided to clinicians. There are lots of options, which is the theme of the application this year. I should note here that, of course, some commercially available electronic health records include embedded clinical decision support tools. We are not looking to see just the existence of decision support within EHRs used by ACO participating providers. We really want to see the ACO providing some sort of strategic guidance or direction to increase provider awareness of decision support tools that align with the ACO's priorities and/or decrease variations in care delivery among ACO participating providers. Moving on to AC4. This criterion is very similar to an existing assessment criterion. This one is about the ACO understanding the risk profile of its population and their needs and targeting clinical programs to address those needs. It requires that the ACO collect data to understand the health needs of its population and then act on that to develop, implement, and refine programs and care delivery innovations to coordinate care, manage health conditions, and improve the health of its patient population. Notice here our particular interest in seeing how the ACO is holding itself accountable by setting targets, tracking how it's performing relative to those targets. This is an instance of the broader ACO Week theme of a focus on learning and improvement over time. The emphasis here is not just on implementing a population health management program, but also a commitment to learning from experience and refining over time based on that experience. For the first part of the criterion, AC 4.1, we are looking to see a narrative of how the ACO stratifies or screens its patients to understand their need for population health management programs. We call out in the PUG a few specific elements that should be included in that description. In the second part of the criterion, we are looking to collect some semi-structured information via completion of a template document that will provide about the population health program or programs themselves, with a particular emphasis on the priorities, goals, and performance targets the ACO uses to assess and refine those programs over time. Our hope is that by laying out the key elements we are looking for in a succinct template, it will be easier for you to collect that information for the application. This is a snapshot of that AC 4.2 template, which is available on the ACO Certification Program website now. As with the risk contracts template, we've put in an illustrative example in red to clarify the template fit. But in general, we are looking for some basic information on the population health management programs the ACO is supporting. What is it broadly trying to achieve? That's the priority area or program column. Very succinctly, what is the program doing? What is the actual intervention? Who is it aimed at? How many folks is it serving at present? And then, as I mentioned, you're interested in what tangible or quantitative aims the program is hoping to achieve, and how has that been going so far? And then we provide a final column where, if applicable, you can briefly describe any major changes that have been made to the program in the past 2 years based on data gathered or targets missed over the course of implementation. What we're looking to see here is that the program is tracking to something and putting itself in a position to understand how the program is performing and potentially iterate over time to improve it. The number of rows that you fill out here will depend on how many PHM programs your applicant and/or component ACO support. Maybe there's just one flagship program in which case only one row would be necessary. Maybe there's a suite of programs. That will vary based on your ACO circumstance. Finally, we turn to AC5. The ACO certification program has been grounded in the belief that the healthcare delivery system should improve health by delivering coordinated, patient-centered healthcare that accounts for patients' behavioral, social, and medical needs. This criterion requires that the ACO recognize the importance of non-medical factors to overall health outcomes and cost of care. In particular, it requires that ACOs seek to integrate behavioral health and connections to health-related social support into their care delivery model. Here we would be looking for information on the milestones and implementation targets the ACO is holding itself to in implementing a behavioral health integration strategy. Similarly, we are collecting information on the incorporation of screening and referral processes for health-related social needs into care delivery. With respect to the behavioral health integration component of AC5, we've developed a template to collect some information, and we'll talk more about that template in a moment. For the health-related social needs screening component, we would be looking to see things like screening tools in use, or response summaries or results dashboards that track screenings and referrals, or written materials like memos, overview presentations, or summaries detailing the ACO's approach to health-related social needs screening and referrals. We understand that for some ACOs, HRSN screening and referrals may be part of the population health management program or programs described in AC 4.2. If the applicant's HRSN screening process is embedded in the applicant's population health management programs described in AC 4.2, the applicant may provide the information required for AC 5.2 in the population health management programs and targets template submitted in AC 4.2. In that case, the applicant would just note in the box in the application that it has exercised that option. And then we would ask that it provide a little bit of additional information on any progress toward or plans for use of bidirectional methods or platforms to refer patients to community services and facilitate communication between the ACO, primary care provider, and community-based service. Here we wanted to show you the template for the behavioral health integration response. Again, there's some red example text to provide some ideas on what a response might look like. You can clear that out before beginning your own response. For this criterion, we understand that there are barriers to behavioral health integration and that this is all a work in progress. What we're looking to see here is some way that the ACO is working to move the ball on this issue. The template is laid out somewhat like the population health management programs template, but we anticipate that the responses in terms of what the priority focus is could take a lot of different forms. What we're looking to see here is broadly what you're trying to achieve and what tangible goals or metrics you're pursuing and tracking yourself. We also ask how the ACO is supporting this work. Is it financial support or some sort of technical assistance or other infrastructure that it is offering up? We also provide a space at the top of the template to provide a few sentences of overview characterizing your overall approach to pursuing behavioral health integration. I want to turn now to the role that health equity plays in the ACO certification standards. As we all know, the events of the past year or so have really shined a spotlight on inequities in our society, not just in healthcare, of course, but certainly in healthcare too. The HPC'S mission is to advance a more transparent, accountable, and equitable healthcare system through its independent policy leadership and innovative investment programs. The agency's overall goal is better health and better care at a lower cost for all residents across the Commonwealth. Health inequities in the Commonwealth have been well documented by the Massachusetts Department of Health, the Center for Health Information and Analysis, the Office of the Attorney General, the Health Policy Commission, and others. Over the past year, the HPC has presented publicly a health equity framework for the agency and is finalizing an action plan with detail on how the agency plans to implement changes to its work to more fully integrate health equity principles and ensure that a health equity lens is applied to all current and future work. Given that action plan and our goals with this certification program, we have given thought as to how best to embed health equity principles into the ACO certification program. Broadly, We view the improvement of health equity as a goal and an approach that is complementary to the framework laid out in the 5 assessment criteria, and one which can and should be embedded into any and all of the core ACO capabilities and functions that we seek to recognize in the assessment criteria. So this year, we are requiring that in responding to any one of the assessment criteria, the ACOs highlight an intentional activity or initiative to address a health inequity. In essence, we are asking that one of the ACO's assessment criteria responses to be chosen by the ACO be health equity themed. We will require that in the response to that particular assessment criterion, the ACO provides certain specific additional pieces of information about the activity, namely the health inequity being addressed, the data or information the ACO used to identify the health inequity initially, and some description of what the activity is and what it aims to achieve. We have left it open as to which assessment criterion the applicant may designate as its health equity response. It can be any one of the 5. There will be a radio button question at the start of the assessment criteria section of the application, where the applicant must specify which assessment criteria response contains the application's health equity response. As we have since the inception of the ACO certification program, we will continue to collect supplemental information as part of the application. These questions are all about collecting some information on ACO's approaches to these issues. We are seeking to make this easy on ACOs, and for the most part, to collect structured data, checkboxes, multiple choice, drop-down. This will allow us to collect some standardized information, much in the same way as some national ACO surveys have for research purposes. However, ACOs always have the option of uploading additional attachments to provide additional context, information, or resources. This information is important both for shedding light on ACO innovations and practices, as well as for informing future modifications to the certification standard. Indeed, the supplemental information questions from prior application cycles help to inform this year's modifications to the standard. We've worked to be thoughtful and deliberate about the areas about which we are requesting information. To that end, we have focused on just 3 topic areas this year, and you can see those here: activities ACOs are engaged in to promote health equity, innovative care models ACOs are supporting, and strategies to control total medical expense growth. One important point to note: to avoid making the application overly complex, we do not ask applicants to answer questions separately for each component ACO. In cases where an applicant has multiple component ACOs, we ask that you provide a response that best describes the overall characteristics or approach across the applicant and all of its component ACOs. We understand this could be challenging to characterize at times, but please do your best and feel free to take advantage of text boxes where applicable, and the option to upload supplementary documents to provide additional clarification if you like. Our first supplemental information area focuses on ACO activities to promote health equity. This includes questions on the patient level, race, ethnicity, language, and disability data that is available to ACOs for different payer populations, as well as a question about other areas where ACOs may be taking steps to promote equity within care delivery models or within the ACO. Second supplemental information area focuses on innovative care models, with a couple questions around what ACOs are doing with respect to supporting digital health and telehealth, and a question about the incorporation of non-clinical personnel into care delivery models. The third and final supplemental information domain has questions about successful strategies ACOs have found to control growth of total medical expenses, as well as challenges to controlling TME that ACOs are grappling with. These questions both ask for the applicants to select their top 3 responses. Now, as ACOs respond to the criteria, it's important to understand the confidentiality protections in place. In setting this policy, we sought to balance the value to the market of having some transparency real business confidentiality interests. There is a small set of data that we plan to publicly report on in an identifiable way, listed on the left in this slide. You can find those basic pieces of information about ACOs in the ACO profiles that the HPC periodically releases. For all other information submitted for certification, the HPC will keep confidential unless the ACO specifically consents to release of information. There will be an opportunity on the application to offer that consent for responses to various questions on the application. It is important to know, though, that the HPC does have the authority to publicly report information at an aggregate, de-identified level. We encourage you to use the PUG to begin working on your applications offline this summer. We at the HPC will be offering weekly office hour calls starting in July. And of course, we're always accessible. You can always reach out to us through the HPC certification email box. We'll be updating the ACO application portal this summer to reflect the changes in this year's application. In August or September, we will offer a refresher on using the ACO certification application platform that hosts the ACO application. This is the same platform that we used in 2019. As a reminder, it's fully web-based with no need to download any software. We anticipate that the platform will open and ACOs can begin completing their applications in September. Now, in the past, we have used October 1st as our application deadline. But due to the unusual circumstances of the past year and their impacts on ACO operations, this year we will offer a rolling application deadline instead. ACOs will be able to submit their applications anytime between around October 1st and the end of the year. Our goal is to provide you with some flexibility as you navigate competing demands. If you want to submit your application earlier in that window, that's fine. We will be reviewing applications and issuing determinations as applications come in. Existing 2019 certifications will remain in effect for ACOs that submit an application by December 31st, pending our review and final determination. You can always reach out to us with questions. The best way to do that is through the HPC's certification mailbox. And you can always find information on the ACO Certification Program website. Office hours will be on Wednesdays at 3 p.m. this summer, starting on July 7th. I will send a calendar hold to the applicant contacts that we have on file, so keep an eye out for that. But of course, if you have questions or want to talk sooner than July, do not hesitate to reach out to us. With that, I think we have a couple minutes left to take some questions from the comments. Unmute Courtney Wright.
Hi, Mike. Can you hear me?
Hi, I can hear you. Hi, Courtney.
Hi. So we have a question, I think it was on slide 6 about the prereqs. They're asking, are bylaws acceptable if they include the descriptions of the governing body and committee?
So this year we've eliminated the requirement that bylaws be submitted, and that's part of the goal of that is to streamline what we're collecting on governance. So we're really just looking for an org chart. We're not looking for additional uploads beyond that.
Okay, I hope that answered that question, and I think that's the only question we've received thus far.
All right, well, if there's any other questions, go ahead and type them in now. Otherwise, we will look forward to chatting with you all either one-on-one or at a weekly office hours in the near future.